Good morning. I'm very pleased to be here. And this is not my first visit to be in Poland. And I'm very much obliged to be in cooperation with the very remarkable persons, with Regina, with Professor Bogdan de Barbaro, and which I heard is on the way to be retired. But as we are used in the academic world, when we retire, we go on with working, and I'm very happy to hear that Bogdan de Barbaro also is giving his large experience in the field, even if stopping to work in the university. So welcome to the club of retired professors. I thought to share you some ideas of the dialogical practice. There is mentioned a book that is also in Polish, and I also had an information that our second book has also been translated and will be published in Polish in the near future. When we speak about dialogical practice, we speak about a very challenging issue. And the challenging issue comes out of the challenge our way of thinking of problems within psychiatry. As we already saw yesterday when we had a consultation with the family, immediately we start to make a diagnosis of the family, what's wrong here and what's not working. But in dialogical practice, we do not do that. And it's a very big challenge to us professionals to follow and start to look at the resources instead of looking at what is wrong with the family, with the patient. And for me, the best person to open up the understanding of the new world is a Russian philosopher, Mikhail Bakhtin. And Mikhail Bakhtin, there could be shown many notes of him, but in one of the notes he says that dialogue is not a threshold to action, it's the action itself. So it's not that we organize dialogues for something, but we organize dialogue for dialogue. It's not a means for revealing, for bringing the surface. No, in dialogue, a person not only shows himself, but he comes for the first time that which he is. And we repeat not only for others, but for himself as well. So dialogue is the aim of the life. It's not the way through which we make changes in the family. And this is so challenging for us professionals to adapt, because we are so educated to do different kind of intervention of the system. In open dialogue practice really is going on. For instance, we have systematic training in more than 20 countries now. It all started in the Finnish Western Lapland, and unfortunately, at the moment we only have a research consistently of the practice, what happens in Western Lapland. I will show you a very interesting research that was published last autumn. And in Western Lapland, in this open dialogue practice, we have 3 inclusion periods of first-time psychotic patients. First of them was 1992 to 1993. This was a national Finnish project, integrated treatment in acute psychosis, in which the aim was to find out what is the role of neuroleptic medication in psychosis. And Western Lapland was one of the research sites in which the neuroleptic medication was not started in the beginning, but it was looked how much the psychosocial help assist. Because of the very interesting outcomes, surprising outcomes, we decided to continue our own research, open dialogue in acute psychosis, 94 to 97. And then, because of many things happened, for instance, our results were that heavily criticized. For instance, a group of Norwegian professors in psychiatry came out and said that this is a fraud. We have excluded the most difficult patients, and in a very nasty way. criticize the idea. But we had an interest to look at if this really is the case, and we replicated the same design 10 years after 2003 and 2005. And in a 2-year follow-up in each of these groups, we could see that only looking at the employment status, so many of the people, 84%, and even 91% could have returned to full employment, which is very different that we are used to think in psychiatry about people who have psychotic problems. We are used to think that more to 60 and 70% are retired, and not to think that 90% of the people can return to full employment. And now, last autumn, I'm sorry, the figure seems not to be in a correct places, but we can read. We made a research about 19 years after what has happened with these people, and we took it's called a register-based study. We took information of the official registers in Finnish statistics and made a comparison of all these people who during these 3 years, 3 inclusion periods, 108 persons, and made a comparison to the rest of Finland, that is treatment as usual, 1,763 patients, and we see very interesting and big differences. First of all, it seems that there is a difference in the mortality by illnesses in these groups, but actually it does not exist because the people who are treated in Western Lapland are younger and they come into the treatment earlier, and when we control this age difference, there is no differences in the mortality rates of the people. But then we can see very huge differences, how much the people are in hospital. In Western Lapland, 18% of the people were hospitalized more than 1 month compared to almost everyone in the rest of Finland. Still 50% of the people had contact in psychiatry after 20 years in the treatment as usual compared to 28% in Finland. On neuroleptic medication was still in 81% compared to 36% in the open dialogue, and this is the most dramatic difference. 61% are living on a disability after 20 years compared to 1/3. You do not need to be mathematically clever to realize how much which is the cost effectiveness of the practices, thinking of people being actively involved and not. This is very interesting result because this is not an outcome research. We do not have a control of the treatment after 2 years. So 17 years time, these people may have been in a very treatment as usual setting. We know that, for instance, 40% of the people do no longer live in Western Lapland. They have moved, and in the crisis, they probably meet with psychiatrists who introduce their medication. But still, in the crisis, they behave in a very different way compared to the treatment. So it's a very, very interesting question that, to ask that something that happens in their lives 20 years ago, when they were facing with a very severe crisis, is still affecting their way of living and in crisis 20 years after, even if we do not have a control of any system. So for me, it means that when we meet with our clients, we do huge choices. We do choices that are visible in our clients throughout their entire life. And there are possibilities to make, let's say, human choices through which we give more author support to have more authorship in their lives than another idea. And for me, it's a question that if we allow the idea of a dialogical practice. Very shortly, in this slide I have a lot of other kinds, but I say some words of this open dialogue because it's one way to organize our system. I don't think that it's only way, but we really have a lot of experience and we really have a systematic training and possibility to take this as a part of the practice. We started to develop it in Western Lapland, in Tornio, some 35 years ago, 1984. Then we heard the idea that Professor Yrjö Alanen and with his team has created these open meetings and stop having meetings among professionals and always inviting the one who has been admitted to the hospital and always inviting the family members into the meetings. And this really made a big difference when we started to do that. And we were very confused what happens. We got a very good outcomes in the very beginning, but we also had a very confusing experiences. And the confusing experiences came out of the idea that when people were invited to be sitting with us, they had a lot to say. They were no longer only listening the plans of the professionals, but they affected a lot of our way of being in the system. Families had a lot of questions. How do they want that our daughter is treated? And in that way, our aim of having a control was in a way conflict with the expectations of the family. And we made two conclusions about it. We realized that we need to have a different kind of education because the basic education is so much oriented to the idea of having a control of the symptoms and making change in the family. And we realized that in this new open system, what is needed to done is to be adapted our behavior to the behavior of the family. And that was the first conclusion. We need to have education, and we started to have 3 years training for the entire staff in Tornio. So actually it's also important to realize that these outcomes that I showed in the beginning, I have never seen that kind of outcomes in psychosis in Norway. But they are done with the staff who has the highest possible educational level within psychiatry, because I don't know any other psychiatric system which all the nurses, social workers, psychologists, doctors have a 3 years training in dialogical family therapy. Second idea that we realized was that we need to make an evaluation of the practice all the time. We need to research, we need to learn our mistakes, we need to have a system in which we follow how to develop the practice, and all this has been going on more or less now for 30 years. In one of the studies conducted by Professor Jukka Aaltonen, Jukka was a student of Yrjö Alanen and also a supervisor in the Western Lapland system. We had reorganized the system by going into home, a kind of community cares, having mobile crisis intervention teams, and when this has been going on 5 years, in the mid of 90s, we made an analysis. How is this system different compared to the system that we are used to meet with people with psychotic problems by hospitalization? And now we were working in a way that when there is a crisis, there is a team going to the home and meeting with the clients. And in this analysis, we came up to the conclusions of optimal care in the new system. We realized that the optimal care is the one that introduces immediate help, is orientated in crisis, that people do not need to wait for help, but they are needed within the first day after the contact. Optimal care always includes the perspective of the family, and some cases also the other part of the social network. That's why we named it as a social network perspective, not only family, but of course family is always there. Optimal care is the one that is flexible, that use all the methods that we have. We do not need to skip any method because we need all of them. We need medication, we need psychotherapy, we need occupational therapy. And all these are used based on the evaluation of the need of the clients in a flexible way. And if we are flexible enough, it seems to introduce the best outcomes. Not only having meetings with the family, but also, for instance, having individual therapy talks and or rehabilitation programs or other forms of psychotherapy. Optimal care is the one that guarantees the availability of the professionals in a way that the professionals take responsibility. We learned a principle that whoever in our system is contacted, whoever in whatever he or this he is working, is responsible for organizing the first meeting with the family. We neglected our staff to say that this belongs not to us, you have to take contact for a clinic, alcohol abuse clinic or other services. But instead we say that, okay, when I listen to you, I realize that perhaps there is some part of the problem also of drug abuse or alcohol abuse. I would like to organize meeting with you. Would it be okay if I invite someone from the A clinic to come to us? In that way, we try to guarantee the psychological continuity across the boundaries in the service system. So open dialogue is an integration of different methods, but it's also integration all the professionals that work in the same problems. And in the end, we came out to realize that when we come into this way of working, our intervention need to contribute safety for the family, to tolerate the situation in which there are no ready-made solutions or conclusions to be made. And for that, we need the dialogue in the meeting. The meetings are not for solving problems, but the meetings are for generating dialogue, to have more understanding of what has happened. And of course, the understanding is for all of us. It's for us, but of course, the understanding is more for the family. Yesterday, we had a session with one family, and the one who was the main person said that I don't understand what has happened to me, what happened when I became a case. It's a huge question to think about, but this is exactly what we are here for. It's so good that we are here for. Now we can start to think about this problem, and if we have a new understanding, we hope that this understanding helps with the family also. Very shortly, so that this is no longer at all a practice in Western Lapland. In Norway, acute team in Tromsø with Magnus Halda and his team is going to present a piece with their work in drug-free world. It has been going on, if I calculated correctly, 25 years already. And a lot of other places, and really all the continents, not in I don't know any training going on in Africa or Antarctica, but all the other continents that I know. And very interesting is the research project that is going on in the UK that is called Odyssey. And this is fascinating in many respects. First of all, it is a research project that is funded by the Medical Research Association in the UK, not the Psychiatric Research Association. And it's the largest ever done research within psychiatry on any psychosocial intervention. It's very interesting. All of a sudden, the mainstream psychiatry also becomes curious, or mainstream medicine, and really want to know how is it. Because if they would not take it seriously, they would not invest £3 million to have this research. So this is going on, and then we also have initiated I try to look at people from Italy in charge of this hope and dialogue research to replicate this a bit in smaller. Giuseppe and yes, here you are. Yes, yeah. And we have ongoing trainings in many countries. In the very end of my speech, I only have a kind of questions that what do I think that are the basic ideas? How come this is very productive? I know that in the mainstream research, they have a very heavy criticism of this research that we have done. They made many questions about very minor details actually. But I don't have any doubts that these results are not real. We have done so many research and repeatedly have the same results, so that we know that this is an effective way of working. And there are 4 hypotheses for me, or a kind of explanation. If these all things happen at the same time, you may expect good outcomes. First of all, if you organize your work to guarantee immediate help, to meet with people in a crisis. And a crisis is a very productive idea because you meet with people with their emotional experience, not so much in the rational explanation of the problems. And being in emotions opens up way to the topics and issues in life that were not possible to share before. Crisis is a very relative, because I have met with clients who have been in crisis 50 years. And after 50 years, we could open up discussions with the family with actually very good outcomes thereafter. So that it's never too late, even if it would be best to start within the first day. Second point is that you need to have the right persons there. You need to be very brave to include the family, other part of the social network, because it's always a question, a kind of shared process. I think that this is the most decisive difference with open dialogue to any other approach, because we are so consistent with the idea to always include the family, and if there are no connection, to look at other options in the social relation, to look at the relational part of the problem. And there are also always resources that we cannot see when we work from the professional point of view. But this is not enough. The third point is that in the meetings, focusing on generating dialogue is like making all the voices becoming heard, making all the voices becoming respected. In the last book that we wrote together with Professor Tom Erik Ansil, we had a motto that the idea of dialogue, the way to genuine dialogue, is respecting the other without conditions. And this is the challenging part. Respecting the other without any questions, without any ideas that he or she has to change or doing differently. And this is so challenging for us because we are so aimed to look at the pathological sides of one's behavior. And this is not dialogical practice, and it's not that productive, that the other way around, looking at the how can we be connected dialogically. And the fourth part is that if we, as we have managed in this way working, decline the role of medication in the treatment. As I said, medication still can be used based on the needs, but there is many harmful effects of medication, and by so doing we can prevent the harmful effects of the medication in a way, and of course I suppose that we need to be more brave to go into the systems without using the medication so much that we are used. And in the very end, my question is all the time, and my experience, because I've been working in this field more than 40 years, and starting with the young psychologist as aiming at to think that if I only learn all the theories and methods, I can help my patients. In some way, I could do that. But nowadays, realizing that changing the practice into a dialogical one, it's a question of more basic values of human life instead of our methods. And of course, there is no more basic value as love. And this is a citation of literature researcher David Petterson, who said that love is the life force, the soul, the idea. There is no dialogical relation without love, just as there is no love in isolation. Love is dialogic, and this is what I see many times in the families who may have been a long time in a crisis. One mother said that I'm so pleased because I learned to love my son with whom I did not have connection for 8 years. And of course, this is very powerful experience that helped to survive in many situations. Thank you.